This is part 2 of Mulligan concept, in which we will be looking at the techniques. Movement with mobilization is the application of sustained passive accessory force or glide to a joint while the patient actively performs the task that was previously problematic. It is used for extremities. This is a picture of MWM to shoulder girdle. In this, the therapist is depressing the shoulder passively while the patient actively elevates his arm. Sustained natural apophyseal glides are called so because therapist applies the sustained accessory zygapophyseal glide while the patient performs the symptomatic movement. Zygapophyseal joints are the joints that connect one vertebra to its adjacent vertebra. It is used for all spinal joints, the rib cage and sacroiliac joint. They are not choice in the conditions that are highly irritable and used when the symptoms are provoked only by movement and are not multi-level. Here is the picture where the therapist is providing SNAG to the affected joint while the patient performs the affected movement, that is flexion. Natural apophyseal glides requires the therapist to apply the oscillatory mid-range to end-range facet joint mobilizations. It is used for cervical and upper thoracic spine, and it is the choice of treatment in highly irritable conditions and is mostly used when symptoms are multi-level. Here is a picture depicting natural apophyseal glide. Let us summarize what we know by now. Sustained natural apophyseal glides are MWMs for spine, and natural apophyseal glides are purely mobilizations without active movement, particularly for the upper thoracic spine. Spinal mobilization with limb movement involves transverse pressure to be applied to the site of relevant spinous process as the patient simultaneously moves the limb through the previous restricted ROM. The belief here is that restriction in the limb is because of positional faults in the spine. So we are correcting it. If you don't know what positional faults are, check out part 1 of the Mulligan concept. It may have neural implications. This picture is of spinal mobilization with limb movements. In this, the therapist is providing transverse pressure to the affected spinal joint while the patient is actively performing limb movement. Pain-releasing phenomena or PRPs commenced for Mulligan when he began incorporating compressions into his treatment protocol when he read article written by G.D. Maitland that was titled The Hypothesis of Adding Compression when Examining and Treating Synovial Joints in 1981. The recommended approach as per the article for evaluating extremity joints involved initiating a compression test to evaluate presence of pain. To execute this procedure, the joint is positioned in biomechanical resting position that maximally relaxes all adjacent structures. With one hand stabilizing the proximal facet, the therapist applies a compressing force to the joint using other hand. While maintaining the compression, a series of joint movements is undertaken to identify whether they trigger pain. This movement can be both physiological actions and accessory movements. Mulligan found that subjecting the joint to a tolerable pain-inducing compression force during movement for a duration of 20 seconds led to disappearance or significant reduction of pain. Hence, the pain-releasing phenomena technique was included in the manual therapy for chronic pain management in extremities. In this technique, joint compression, muscular contraction or stretch is used as pain-provoking stimuli and the stimuli is maintained for 15 to 20 seconds. If indicated, the pain will reduce in this period and or completely disappear. Here is an image depicting pain-releasing phenomena technique for chronic shoulder pain. Now that we are done with all the techniques in the Mulligan concept, let's see how Mulligan is similar and different to others. It is similar to Kaltenborn with respect to joint mechanics. Mackenzie and Mulligan uses self-management through repeated movements, and with Maitland in the fact that change in pain is an indicator of treatment progress. Now the difference is, it doesn't have a grading system. The practitioner will apply as much force in the mobilization as is required to improve the CSIM, and Mulligan is unique because it combines both passive and active movements. Here are few indications for Mulligan concept ranging from headaches to ankle sprains. Here are the absolute contraindications and relative contraindications for Mulligan therapy. Along with that, we need to be precautious for the following: elderly patients or those with compromised bone quality, neurological conditions affecting sensation or proprioception, and cardiovascular conditions. Here are the references for this video. If you like the video, like, share and subscribe.